Okay, guys, let's do a case study. It's been a while since we've done clinical stuff, and I know we talked a lot about sales and the shift, but let's get back to doing some case studies. So I want to go over a case study with you. I think we've talked about this patient before, but she had a huge flare-up. So I want to talk you through what happens when you're getting good results with a patient, you think you're ready to discharge, and then boom, everything blows up. What happened? Why didn't it work? Okay. So this patient is a cheer patient with a hip problem, which I started seeing probably in like September. Came in and kind of sort of maybe looked like a labral hip, acetabular labral tear problem. Started working with her and she cleared up pretty quick. So she went from not being able to do really anything at cheer to going back to cheer within 2 visits. Everything felt fine until she started doing certain movements. Okay, so we've talked about this before, and this is a huge component of the 180 system, and this is a huge component that they completely miss in PT school. Okay, so the important thing when I'm evaluating her and I'm listening to her tell me what positions don't feel good, what positions she fails, that kind of stuff, it's not where the pain is. Okay, so if you have a shoulder patient come in and say, my shoulder hurts here or here or here or wherever, when I am in that position, it's not where the pain is that you should be paying attention to. It's the position that their joint is in and the direction it's going. Is it an eccentric contraction or is it a concentric contraction? Okay, that is much more important than the location of the pain. So anybody who says, well, where does it hurt? Okay, let's go treat that spot, just completely got screwed up and the patient's not going to respond. Okay, you might get response as far as reduction in symptoms because they say, oh, my shoulder hurts there, and you go do stem and heat and ice and K-tape and cupping and needling and stretching and soft tissue release and blah, 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 whatever. So yeah, that stuff will make that feel better because you're overloading the proprioceptors to feel tactile stimulation or electrical stimulation or needles or whatever. And so they'll feel better until about an hour later when everything comes back, which is what people say happens with physical therapy all the time. Okay, so it's not the position. So when we're talking about this patient, when I'm running her through the screen, she can touch her toes, she can lean back, she can turn, she can squat. She's got pretty much no problem. So when I ask her, what is it at cheer that bothers you? And she says, well, when I do this, and then I have to think, I have to use my critical thinking skills, which you'll learn on the shift. I have to use my critical thinking skills. How can I replicate that position eccentrically or concentrically now in the clinic with a clean environment? So I have her do a little step over with rotation movement, and she was like, yep, there it is. So she could touch her toes, she could lean back, she could trunk rotate, she could full depth squat, she could single leg squat, she could march in place, she can do hip abduction, she could do adduction, no problem. But when I have her do a step over, which not only has abduction, but also rotation, now we have the symptoms come back. That's the important thing. What position was her hip in an abduction and internal rotation or external rotation? That's what I got to figure out. What's not working there? Okay. Now you might be thinking, well, if she has a labral tear, obviously the labral tear is the problem. That's why she has pain in that position. And you would be partially correct. Okay. So let's see why that's only partially correct. Okay. So let's reverse. So she was coming in, doing fine, doing well. We got her totally pain-free. So now I'm going to take her in the gym. We've gone over this before in the Facebook group. I'm going to take her in the gym and I'm going to fatigue her and see what happens or how fast or what causes her fatigue. Okay, so we do lunge walk with a twist, crossover walk with a squat, weighted squats, full depth squats, no problem. We do some vertical jumps, no problem. We do A skip, no problem. We do B skip, no problem. We do C skip, and boom, there's the symptoms back. Because what does C skip have that none of that other stuff has? Abduction and rotation. Okay? So once again, I just put her back together. I went through a bunch of stuff that included checking abduction, checking internal, external rotation, clean that stuff up. Now she does C-skip, boom, pain comes back. What do I do? What would you do? Think about that. What I would do is put her back on the table and figure out which one of the muscles that I just worked on is now inhibited again. So when I put her back on the table, we go to deep hip rotators, so gemellus, quad fem, obturators, fail, 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 pain, pain, pain. And before I took her in the gym, I just worked on those things and those were all passing. Okay, so I go back, treat those. Trying to think if I treated anything else. Might have treated psoas, major, and then take her back in the gym, redo, just go right to C-skip. How's that? That's better. Okay, but I know if I have her keep on doing that, we're gonna fatigue again. So now think, okay, we figured out gemellus, obturators, quad fem, psoas major. So those are the ones that are the big ones for her that start the ball rolling and everything comes unraveled, okay? So what are we gonna give her for a home exercise program? Think about it. What is going to, when she's by herself, her problem isn't gross strength. So remember, we're not dealing with a gross strength issue. We're dealing with a facilitation issue. How do we reverse inhibition when they are on their own with a home exercise program? We give them isometrics for the muscles that are becoming inhibited the quickest. So I'm going to give her an isometric for psoas major. Now isometrics for quad fem, gemellus, and obturators is not easy. So I give her some rotational hip rotation isometrics. Tell her to follow up her isometrics with what? So what do we follow isometrics up with? End range of motion, loaded, aplanar, transverse plane motions in and out of end range of motion. So lunge walk with a twist, crossover walk with a squat. Okay, send her home. She comes back. Yep, I feel good. I'm doing everything at cheer. I just get a little bit irritated at the end of practice or at the end of cheering for a whole football game. Okay, so now I've done a scour test. I'm pretty sure that we're dealing with some type of, whether small or medium, labral pathology. So now I've referred her to a physician who is a specialist in labral pathologies, who's a 2-hour drive away, because I'm not going to let her see the yo-yo in town who doesn't know what he's doing, because he would totally screw this up. So I get her off to him. Okay, so that's where we were about a month ago. Everything was fine. She was getting through. She could keep things going with her home exercise program, but we've got this underlying issue that I'm pretty sure is a labral tear that we're going to have to address, because once cheer gets over, she's got a month or two off, and then she goes right into track. So I want to get this month or two to get her all the way back. All right, so doing fine until she comes in this week and she's limping, and she said, everything is worse. It's almost as bad as when I came in to originally start seeing you. And I was like, what happened? And she said, well, I was laying on my bed, and so it's her left. So she's laying on her left side with her left leg forward, laying on her bed, and her mom comes in and sits on her thigh, her femur, and twists and rotates her hip. All symptoms come back. Okay, so now, oh crap, we're back to square one. Nope. I already know what the problem is. I already fixed it once. It's the same thing. It just got irritated from some external force putting way too much pressure and compression on it and twisting it further than it can go. So we already know the answer because I've already fixed it once. So I just go back and do the stuff that I've done before. And what do you know? A half an hour after limping in, she walks back out. She can skip, she can jog, she can walk, she can step overs, Everything's back to normal, back to where we had her before. And oh yeah, she did go and get an MRI. And oh yeah, she does have a labral tear and she is scheduled for surgery in I think 3 weeks. Okay. So now put that whole scenario using a systematic thought process that's based on physiology, that gives you critical thinking skills, that gets you to the root cause, that keeps you following a checks and balances process so you know how to assess your work as you're going through versus what they taught you in school. Find the painful spot, work on the painful spot. If that doesn't work, then they're just non-compliant or they have to have surgery. Okay, so not only did I get relief of symptoms, but she got all the way through her cheer season. Now tomorrow, she's going to state cheer competition. She's going to do the whole thing with a labral tear and be totally fine because did I fix the labral tear? No. Did I get the compression of the femoral head grinding on her labral tear to go away, because now instead of her hip being compressed and grinding, she's got room because all of those deep hip rotators are pulling her away. So think of the same thing when you're dealing with somebody with shoulder impingement. If that rotator cuff is not sucking them out to give them more room to get through the range of motion, they compress, they have symptoms. Same thing in the hip. Okay, even more so because you've got a true deep ball and socket joint. So now that I've got those deep hip rotators pulling her out to get her more range of motion, psoas major, we also worked on vastus lateralis, glute max, glute med, all that stuff, soleus, transverse abdominis. So we just didn't work on hip. We had to work on the entire kinetic matrix. Now we've got her more range of motion so she can go do whatever she wants to be doing and be totally fine, even though she still has a labral tear. That's what you get when you have a systematic thought process. What you don't get when you do what they teach you in school is results, is full return to play, even though you have pathology, getting through an entire season, giving them something that they can use at home. So she knows when she starts to feel certain things come back, these are the things that I do. She understands why she does isometrics. She understands why she does motion, full range of motion, weight bearing, transverse plane, in and out of end range of motion, full pronation, supination exercises to follow up the isometrics. The sad thing is most physical therapists don't understand any of that because they didn't teach you that in school. But I just taught a high school junior everything she needs to know about her pathology, how to assess it, how to self-treat it, how to scale back or progress. And most PTs don't even know that. Okay, so there's your case study. Now ask yourself, can you do that with your skill set, with your thought processes? And if you haven't been through the shift, you can't do that. So when you're ready to be able to do that and give your patients real results, let me know. I'll get you in the shift. Stick around, come back later this week and we'll start doing more case studies. Give me your thoughts and questions in the comments below. If you've got a pathology, diagnosis, body part case study that you want to see, post it in the comments below.